Hi, everybody. This is Suzette Benford from the Alzheimer's Association, and today we'll be doing Module 3 of our dementia training, which is behavioral symptoms. In this module, we'll be talking about the behavioral symptoms of Alzheimer's and other dementias, and behaviors are a major source of stress for caregivers. It's one of the issues that we get the most calls about and the most requests for education and assistance. And I think that if we can help caregivers learn to, number one, get educated about the disease in general, number two, educate them about not arguing with and not correcting the care receiver, and number three, help them to learn to deal with the challenging behaviors, those things will help them as much or more than anything else we do for them. So what are we really talking about when we talk about, when we talk about behavioral symptoms? We're talking about manifestations of the disease process. They're expressions of the disease. And as the disease progresses, obviously people are going to have more trouble communicating to us how they feel, what they want, and what they need. And so those things come out as behaviors. So examples of these things can include agitation, aggression, wandering, hallucinations, paranoia, getting very disinhibited, or sundowning. We have to also teach caregivers that behavioral symptoms are not intentional. The person is not trying to be difficult, and it's not because they're just not listening to us. We even have a video here at the office called "He's Doing This to Spite Me," because so many caregivers have the feeling that these behaviors are just being done to aggravate the caregiver, or the person really knows what they're doing and could do better if they just tried. So we have to teach caregivers to really stop and remember when these behaviors occur that they're just part of the disease process. Their mantra really needs to be, it's not the person, it's the disease. It's not the person, it's the disease. So we have to teach caregivers to stop before they react to the behaviors. And I think sometimes it's one of the most difficult things for caregivers to learn is the patience it requires to really stop before they react to behaviors. I often think of caregivers as needing to be like detectives, and that goes for family caregivers and professional caregivers as well. It's like trying to figure out exactly what is this person communicating. What are they trying to tell us? Why are they trying to tell us this? Is something wrong? Do they want something or need something? And also, we have to remember that we're looking also for the feeling that the person is having underneath all this behavior. So what is this behavior really telling us? One of the ways that we can teach caregivers how to go through this process of dealing with behaviors is the IDEA model. There are a lot of different models out there, but this is one of the simplest and easiest ones. The ID part of IDEA is identifying behaviors. So what is the specific behavior that we're looking at? The E part is educating yourself about the causes or triggers and the meaning of the behavior. So really, the E part is, in a nutshell, figuring out what the person is telling you with the behaviors and why. And then the A part is problem solving, adapting, trying to adapt to their behavior by using different strategies that will help them feel better. Okay, so let's break it down in the different components. The ID part, the identifying behaviors and problems, we need to think about what is the specific behavior that we're looking at. Is it observable, measurable? Can other people see it? So let's give the example of agitation. That's a very broad term. We say somebody is agitated. But we have to think about what's the specific behavior that we're looking at. If somebody's agitated, they might be pacing. They might have restlessness. They might be repetitive, asking repetitive questions, those kind of things. So we need to think about it in terms of what is the specific behavior that we want to address. And then the next part, of course, is the E, the educating yourself. And we need to, when we're doing this, first of all, understand what's causing the behavior, and are there any triggers? Is there something that's setting off this behavior? And so some examples of things that might be causing the behavior are health issues, psychosocial needs of the person, environmental issues, task-related things, and communication difficulties. And we'll talk individually about each one of these. Okay, so that, first of all, the health and physical triggers. Some examples of sudden and unusual changes that caregivers should look for are sudden incontinence, sudden disorientation, sluggishness or agitation, could be really moving slowly or very restless, sudden decreased attention, inability to focus, and new aggressiveness. And we need to really educate caregivers that these sudden changes really should raise a red flag, and they really need to talk to their doctor about those. Because if we do that, sometimes we can say the person has a UTI. If we can deal with that immediately, we can fend off a lot of behaviors and a lot of pain and suffering for the person. Okay, so some of the reasons that we might be seeing the sudden changes are delirium. If somebody has a physical illness underlying this, they can get delirious. They can have infections. We mentioned UTIs, fever, dehydration. Dehydration is, one of the most critical aspects of caring for somebody with dementia. They often don't want to drink enough, and so sometimes we really have to be mindful of pushing fluids through the day, because when people get dehydrated, there are a myriad of different complications that can result from that. And then also sudden and unusual changes can be caused by being malnourished, constipated, people just being tired, having pain. And I think, unrecognized pain is very, very common with people with dementia who can't communicate to us. And so we really need to be on the lookout for behaviors that might indicate to us that people are in pain. And then we also have medication reactions and interactions. And then we need to think about also if people are having changes in their vision or hearing, that can affect their behavior as well. Okay, so, and we need to remember that when people do have an undetected illness, they are more likely to refuse care. So if you're trying to help them with their personal care, bathe them, they're more likely to, refuse that, or maybe even be physically aggressive. And also, obviously, they're more likely to have lower cognitive function. They're more likely to be hospitalized. And unfortunately, they're much more likely to be prescribed psychotropic medicines for their behaviors, when really it's just underneath it all is an illness. Okay, so now we're moving on to the psychosocial triggers. I think caregivers really need to remember that as dementia progresses, people are often feeling just really lost and sometimes fearful. And because they're not able to communicate as well as they once did, that can be really, really frustrating for people. And also, we need to remember that people might not be getting the socialization or interaction with other people that they once did, and they might be feeling lonely. Or if there are too many people around, that might be too much socialization for them. It might be too overwhelming for them. And then we all have emotional needs of needing to feel comfortable, secure. We need to feel like we belong where we are, and we need to feel like we have a purpose. And for people with dementia, those things often go away. We might not feel like we belong where we are, and we might not feel like we're of any use to anybody anymore. And so those things can really be psychosocial triggers for behaviors. Okay, now we're moving on to the environmental triggers. People with dementia are very sensitive to changes in their environment, in their routine. If they live at a facility, if they're a new staff, those things can really throw them off. And then clutter. I have heard many people, even with early dementia, say that the more cluttered their environment is, the more agitated they feel. And decluttering an environment can really, really be helpful for people. And then noise. People with dementia are very sensitive to lots of noise, or if people are speaking loudly, if there's loud music, that can make them feel very uncomfortable. And of course, temperature. If the room is too hot or too cold, and they don't have any way to tell you, that can make people very upset. And they might be distracted by lots of other things in the environment. Again, too many people talking, too much going on, people coming in and out of the house. Those things can cause agitation. And then lighting. People with sundowning symptoms, often as the light goes down at the end of the day, their sundowning symptoms increase. And so if we try to increase the lighting throughout the day, sometimes that can help. So really we need to teach caregivers to sort of put themselves in the shoes of the person that they're taking care of. Think about if you were cold and didn't have a way to tell somebody you needed a sweater or a jacket, how would that feel and what would you do? If you were being forced to take a shower in a bathroom that you didn't recognize or that felt really cold to you, how would you react to that and how would you feel? Or if you looked in the mirror and you didn't recognize yourself and you really thought that there was a stranger in the room with you, how would you feel? And that often happens with people with dementia. They look into the mirror and they don't recognize the person that they see because they might be thinking of themselves as somebody at a younger age. And so they think there's someone else in the room. And that's the reason that many times in people with more advanced dementia, caregivers sometimes will put butcher paper or other paper on mirrors so that people don't see the reflection. Okay, now we're moving on to the task triggers. If you're asking somebody with dementia to do something that is too complicated for them or has too many steps, or they're maybe not used to doing it in the way that you're asking them to do, the task, that can be a trigger. And the communication triggers. Obviously, as people's dementia advances, it is harder for them to understand what's being said, their receptive communication, and it's harder for them to say what they want to say. Their expressive communication is affected. And so that can be a real trigger for people when they can't understand what you're saying and you're not understanding what they're trying to say to you. So we're really trying to get to the meaning also of the behavior. What does it mean to the person that's exhibiting it? What does it mean to the caregiver? And really, who is it distressing for? Is it distressing for the caregiver? We really need to think about if someone is walking around the house, looking at things, checking things out, but they don't seem, to be upset by that. They seem pretty calm. We have to think about, is that really a behavior that requires or needs an intervention? If the behavior is not upsetting to the person, or if it's not harmful to the person or to anyone else, then maybe that's something that it would be better to just sort of let the person continue to do. Sometimes if we interrupt or interfere with somebody who's doing something like that, the consequences can be worse. They can get really agitated when that happens. So we think, who's it a problem for? Okay, and then we have to, again, be looking for the meaning underneath some of the behavior. So when someone says, I want to go home, what does that really mean? We have to think about, what does home really mean to them? For a lot of people, home means a place where you feel comfortable and safe and secure. And if a person isn't recognizing the surroundings that they're in as their home, they might be telling you, this doesn't feel right. or I'm just generally feeling, uncomfortable and unsafe, and that might be what they're trying to convey to you. Or someone might be thinking about home as literally a place that they lived in when they were younger, and so the home that they're in doesn't just look familiar to them at all, and they want to go back to another place. And if we say to the person with dementia, "But Mom, you are home," that is really probably just going to agitate the person even more, because to them, they really believe that they're not home. And if you argue with them about it, they'll just get more agitated. So a better response to teach a caregiver might be, "Well, Mom, tell me about your home. What does your home look like? Tell me about the neighborhood that you live in. Tell me about your neighbors." And if you get people engaged in answering questions like that, sometimes that can redirect them from the feeling that they were having of maybe, being uncomfortable or unsafe. Okay. And so again, we're looking at there are no solutions for these issues. There's never a 1, 2, 3 guide to, if this behavior happens, you follow steps 1, 2, and 3. We're trying to train caregivers to look for strategies to deal with those things, while always paying attention to the person's feelings. How are they feeling underneath that behavior? So moving on to the last part of the model, the A part, that's adapting. So that's really just, the person with dementia can't adapt. It's the caregiver who really has to adapt to the person's behaviors. And so sometimes you have to try different things. And one strategy or technique is not going to work with every person, and it's not always going to work on the same person on different days. So we really do sometimes have to do it by trial and error. And if the caregiver sets the tone and really stays calm throughout the process, that gives you the best chance of success. It's very difficult for caregivers sometimes not to become anxious themselves or show that they're frustrated or impatient. But if we teach the caregivers, again, to stop and take a deep breath and really try to stay calm and pleasant and warm and loving, that's the best course of action. Okay. Now, one method that caregivers might use is distraction and redirection. So we talked about one example of when the person asks when the person says they want to go home, you say, "Well, tell me about your house and tell me about your neighborhood." Another thing might be offering the person something they really like to eat. If you know that they really, really love ice cream, for example, you might offer them some ice cream. Watching TV or listening to music. We don't want to be watching TV all day, obviously, and just kind of sitting there staring at the TV. But if they really love I Love Lucy, you can maybe pop in a DVD of that, or listen to music that that they really like. We'll talk more about music later. Or asking the person for help with a simple activity. Again, so many times people with dementia feel that they've just lost their usefulness. And we all want to feel like we're of use to people and have some kind of purpose. So just having something like having them maybe fold laundry for you, just something easy, and you have to make sure that the activity that you're giving them is something that they're able to do, that won't be frustrating for them. But it could be also just a simple activity like going for a walk, or just leading the person to a different room. Having a change in environment sometimes can help. And then, again, keeping the activities very simple. If you are going to give them something to do, just break it down step by step. And try to have the activities meaningful if you can. If the person, for example, was, say, somebody who worked in an office, if you could sit them at a desk and ask them to organize the office supplies, or something that they think would be helpful to you, that's a great example. And then keeping the house as calm and quiet as possible, just making sure that the environment is as restful as it can be for the person. and then comforting them. I think sometimes we forget to say, you know what, I know you're feeling, sad or unhappy or restless right now, but everything is okay. Everything is really going to be okay, and I love you, and I'm going to be here with you. Okay, now let's talk about communication strategies. And obviously, strategies are going to be different for people in early stage. People who are in very early stage, like the folks that I work with, I speak to them very much like I would anybody else. As the person progresses, though, you might need to alter the way that you speak to them some. But in very early stage, sometimes caregivers are tempted to ignore the person's opinions because they do have impairment in some areas. They sort of assume that their impairment goes across the board, and it's not always the case. So we really want to be respectful of the person and still treat them as though their opinions have value, which they do. And you want to keep the person involved in their own plan of care. In very early stage, for example, if you're talking about a plan for the person not driving anymore, it's great to have them involved in that process to the degree that they can be. Not everybody is okay with making a plan for, your brother or sister to drive them to the doctor instead of them driving. But to the degree that they can, it's good to keep them involved in the plan that you're making for them. And we've talked about this a lot, and it's a good thing to reiterate over and over again, not to argue with or correct the person, or to ask them constantly, who am I? Do you know who I am? Because that's just agitating. And don't remind the person that they forgot. If you say, Mom, you asked me that 5 minutes ago, that just makes the person feel bad, and it really doesn't help anything. So here are some communication strategies for people who are now in middle stage. You have to allow more time for them to respond to you. Sometimes it takes people longer to kind of gather their thoughts and say what they mean. And then talking to them in a space where there are not many distractions, or speaking to them one-on-one. And you see in the photo there, the person is kind of getting down at eye level with the person. That can be a really helpful technique to use, making sure that you're in their sight line. And again, avoiding criticizing them, avoiding correcting them, and avoiding arguing. I often tell caregivers that you have to give up your need to be right. You're just going to have to let the person with dementia be right most of the time. And then many times it's helpful to repeat what you've said just to clarify for the person what you're saying to them. Also, don't overwhelm the person with lengthy requests or instructions or explanations. I think a lot of times caregivers fall into the trap of, trying to explain themselves to the person, and the explanation gets longer and longer, and the longer it gets, the more you're going to lose the person. And if you're asking them questions, just ask one question at a time. Avoiding open-ended questions. As people are getting into middle stage, many times it's better to ask them yes or no questions. That way it helps them respond. And again, to always use a calm and gentle tone, and pleasant. So now we move into the communication strategies for people who are in late stage. It's very tempting sometimes to talk about the person as if they're not there, but we really need to try to avoid that, because many times people will be aware that you're doing that, and that doesn't feel good. It's a good thing to approach from the front, because people with dementia start to lose their peripheral vision, and identify yourself. Hi, Mom, it's Suzette. It's your daughter. And then encourage nonverbal communication. If the person can't really say yes or no, maybe you can model nodding your head or shaking your head. And then, again, gentle and calm tone of voice. And we are always looking for the feelings behind the words or the sounds that they make. And also sometimes in this stage, using gentle touch, visual things, sounds, smells, and tastes, things that can communicate via the other senses are more helpful than trying to actually speak to people. So here's a little case study, and we'll just go through quickly using the IDEA model. Juanita tells you father is agitated in the afternoon. He's wandering, saying over and over again that he's looking for his daughter, and he says it's time for her to be home from school. So first of all, we're teaching the caregiver to identify what's the specific behavior here. What are we looking at? And the behaviors in this case are wandering and the repetitive questions asking for the daughter. So the next step is to let's understand the cause or the trigger of the behavior. So one of the causes might be that he's sundowning. It's later in the afternoon, and the light's going down, and he's getting a little bit more restless. The father might be just confused and disoriented, or he's bored and he doesn't have anything to do. And that's what's really causing the behavior, or that's a trigger for the behavior. Or another trigger might be maybe he's been watching TV and he sees a little girl on TV and he thinks, oh, my daughter, it's time for her to be home from school. And the final part of the next part of the model is understanding the meaning of the behavior. So what's underneath that behavior? What's the feeling there? What's the meaning of it? And so here we have that dad is feeling anxious. That's the feeling under the behavior. And it means that he feels like he needs to exercise his responsibility as a parent. He needs to make sure that his daughter is safe. So here's the final aspect of the model, and that is adapting to the behavior and trying different things to help Dad feel better. So because we think he might be sundowning, again, increasing the lighting before the sun goes down, and then maybe just talking to Dad about daughter, saying she'll be home later, and then redirecting him or distracting him, offering him something to eat or something else to do. And something meaningful is best. If he really likes to walk, go for a walk if the weather permits, or sometimes you can even just walk around the house and go to a different spot in the house. And again, being calm and gentle with your tone. We keep stressing that because caregivers, often need to be reminded of it, and being reassuring. And also wanted to mention to you that your AAA will have handouts about the different aspects of the things that we're talking about. So this says in your packet that was done for the live trainings, but your AAA will have access to an electronic copy of some handouts on behaviors and communications. And sometimes you can actually give these to the caregiver or sit down with the caregiver and talk to them about them. We mentioned earlier that many times behavior is treated with pharmacological approaches before behavioral approaches have really been tried. And we want to talk about alternatives to that. And we want to really try to move away from the pharmacologic treatments because older adults with dementia are much more vulnerable to adverse reactions when they're taking medications. They're more likely to fall and have other adverse reactions. And they're really not shown to be more effective than behavioral approaches. If you look at the research, good behavioral approaches tend to be just as effective as the pharmacological approaches. And then, of course, another thing is to just educate caregivers in models like IDEA, and hopefully that will prevent the need for moving to pharmacological interventions. And having said that, there are some times when all behavioral approaches just don't work. There are some cases where it might be appropriate, but that's a decision that is to be made, with the doctor's cooperation. But let's talk more about non-pharmacological alternatives or intervention. Of course, educating the caregivers is number one. Exercise can be really, really helpful. for people with dementia. And it's actually one of the only things that research consistently shows will actually help slow down the progression of the symptoms of the disease and keep people stable for longer. And then, of course, we talked about meaningful activities. Getting people into a good sleep routine can really help. For people who are having incontinence, putting them on a toileting schedule, asking them if they need to go to the bathroom every couple of hours or actually taking them in regularly, that can help. And then playing soothing music or music that the person particularly likes. Now, speaking of music, next we're going to see a fabulous video from a documentary called Alive Inside, and you can actually stream this documentary on Netflix and watch the whole thing. I highly encourage you to do that because it's fabulous, and it's about an hour and 10 minutes long. But we're going to see an excerpt from that documentary which shows the power of music for people with dementia.
I have one resident that barely opened her eyes. She didn't respond. As much as I tried, I knew her for 2 years. No matter what I tried, massage wouldn't work, nothing worked. But when we got introduced to the iPods and the family told me the things that she liked, it was amazing once we put the iPod on her. She started shaking her feet. She started moving her head. Her son was just amazed. Okay, can we stop? Because now I'm getting all I'm seeing her all over again.
Hi, Papa. Hi, Papa.
Huh?
How you doing?
I'm all right. Fine. Wait.
Who am I?
I don't know. Wait a minute. I don't know.
Okay, it's Cherry.
How long has he been in the nursing home? Approximately 10 years. He was having seizures, and my mother couldn't handle him at home. Of course, it affected me greatly because he was always, fun-loving, singing, every occasion he would come out with a song, no matter where he was. I remember as a child, he used to walk us down the street, me and my brother, and he would stop and do Singing in the Rain. He would have us jumping and swinging around poles. He was, he was good. He was always into music, always loved singing, dancing.
His name is Henry Dreyer.
Uh-huh.
And I'm looking more or less for religious music for him.
Okay.
Because he enjoys music and he always quoting the Bible. So I'd rather have that for him.
We first see Henry inert, maybe depressed, unresponsive, and almost unalive.
Henry.
Yeah?
Henry.
Yes, sir.
I found your music. You want your music now? Okay. Let's try your music, okay? And then you tell me if it's too loud or not.
Then he is given an iPod containing, we know, his favorite music. And immediately he lights up. His face assumes expression, his eyes open wide. He starts to sing and to rock and to move his arms, and he's being animated by the music.
And he used to always sit on the unit with his head like this. He didn't really talk to much people. And then when I introduced the music to him, this is his reaction ever since.
The philosopher Kant once called music the quickening art, and Henry is being quickened, he's being brought to life.
Yeah?
I'm going to take the music for 1 second, okay? Just to ask you a few questions. Okay? I'm going to give it back to you.
Uh-huh.
Okay.
The effect of this doesn't stop, because when the headphones are taken off, Henry, normally mute and virtually unable to answer the simplest yes or no questions, is quite voluble.
Henry,
Yeah?
do you like the iPod? Do you like the music you're hearing?
Yes.
Tell me about your music.
Well, I don't have none, I mean.
Do you like music?
Yeah, I'm crazy about music. You play beautiful music, beautiful sound. Beautiful.
Did you play music when you were, did you like music when you were young?
Yes, I went to big dances and things.
What was your favorite music when you were young?
Well, I guess, well, Cab Calloway was my #1 band guy I liked.
What's your favorite Cab Calloway song?
Oh, I'll be home there for Christmas. Oh, you can count and plan on me with plenty of snow, mistletoe, present wrapped around your tree. Ow!
So in some sense, Henry is restored to himself. He has remembered who he is, and he's reacquired his identity for a while through the power of music.
What does music do to you?
It give me the feeling of love, romance. Figure right now the world need to come into music, singing. You got beautiful music here. Beautiful, oh, lovely. And I feel the band of love, the dream. The Lord came to me, made me holy. I'm a holy man. So he gave me this sound. I'll just say, I meet you. Let me see. Rosalie, won't you love me? Rosalie, won't you be sweet and kind?
With this beautiful new technology, you can have all the music which is significant for you in something as big as a matchbox or whatever. And I think this may be very, very important in helping to animate, organize, and bring a sense of identity back to people who are out of it. Otherwise, music will bring them back into it, into their own personhood, their own memories, their own autobiographies.
I just love that video, and I hope you enjoyed it. It really shows how powerful music can be, and even though this particular video was set in a nursing home, family caregivers can use this at home as well. Okay, so now we're moving on to reducing avoidable hospitalizations and readmissions. And of course, in Module 1 of this series, we talked about the overwhelming burden that the Alzheimer's crisis places on the healthcare system. And we have so many avoidable hospitalizations and readmissions. That's one of the huge costs associated with this problem. And so next, we're going to see another video. This one is shorter than the last one. It's from CNN, and it talks about a study that shows that hospitals can be dangerous places for people with Alzheimer's.
Now, if you have a family member or a friend who suffers from Alzheimer's disease, I want you to listen to this. A new study indicates that a stay in the hospital could have disastrous consequences. Researchers at Harvard took a look at this, and they found that if Alzheimer's patient is hospitalized, it seems to increase the chances of that person being in a nursing home or even dying within a year. Now, here's the key. Many of those hospital stays are for things that could have been prevented. So, Bill, what can people do to make sure that their family members don't end up in hospitals? And that's not to cast aspersions on hospitals, but this study indicated that there are a lot of things that happen to folks with dementia and Alzheimer's that are preventable or maybe not things that you take people to the hospital for, but it just may seem that way.
Well, certainly there are a number of things. One is to make sure that if you have an elder that's having cognitive difficulties, that you get a diagnosis of Alzheimer's disease so that, in fact, you can convey that to the medical care system. the other things that you can do are to be careful that you're being vigilant around other kinds of problems that a person with Alzheimer's disease will have, because they don't go to the hospital with their Alzheimer's disease. They go to the hospital because their diabetes is out of control, or their heart disease is out of control, or they've got some kind of infection. And those are things that you can often manage early and better at home than actually being in a hospital setting.
Okay, so here are top reasons for hospitalizations in this population. We've got the physical, congestive heart failure, UTI, syncope, falls, trauma, and then the mental, which are delirium and psychoses, the behavioral, agitation and wandering, and environmental. And so for each one of these things, we really have to look at if there are behaviors present that might indicate that somebody has, for example, a UTI, maybe the behavior can trigger the caregiver to get that treated before it gets bad enough for the person to have to go to the hospital. Or if they are having agitation, how can we figure out how to approach that with a behavioral intervention before it gets bad enough for them to actually go to the hospital. So again, it's about proactive assessment and early detection of acute illness, teaching caregivers about sudden and unusual changes, and recognizing the person's baseline so that they can see variations from that, managing coexisting conditions effectively like diabetes and high blood pressure. And again, of course, teaching caregivers how to use the IDEA model or another behavioral intervention model. And really, again, caregivers feeling like they're supported by others and that they're educated about the dementia will really help them to effectively manage behaviors and to deal with the challenges that sometimes dementia presents. And these things put together can really help minimize the risk of elder abuse. Even the best of caregivers gets very frustrated and very angry sometimes, and sometimes resentful. We hear that in support groups a lot. Even the best caregivers have these feelings. And the better that we can support them and educate them on techniques that they can use to help with the person's behaviors and with their own stress, the more we minimize the risk of the person with dementia being the victim of abuse. And that is all for this section. I hope you enjoyed it, and we will be seeing you again in the next section. Thank you so much, and have a great day.